Hi everyone, welcome to another edition of the Right Way Wednesday. Today I have Loretta Bartz from the Clinical Strategies team with me, and we are going to continue to talk about PDPM. Today, Loretta and I really wanted to talk through the occupational therapist role in PDPM and what they need to be focusing on when looking at documentation. And with PDPM right around the corner, almost less than a month now, right? Loretta, what do our OT and CODAs need to really be thinking about in terms of documentation at this point, focusing on?
Well, I think, as they probably have heard multiple times as we've done education with PDPM, is really we have to work at the top of our license. I'm gone are the days of just kind of moving through the system without truly thinking about what this patient needs to get to the next level of care. That's not changing with PDPM. That has been around with safe transitions for greater than 4 years now. What is changing, though, is truly seeing our role within the IDT team, collaborating with nursing, other disciplines, to truly paint the picture of who this patient is. What are their comorbidities, the complexities that we need to address and capture to ensure that what we're doing for that patient is also reflective in the reimbursement we're getting.
Right. We've been talking a lot about, right, focusing, like you said, focusing on function, which is going to help us get there versus things just to fill our treatment sessions, right?
Correct.
Yeah.
Correct. And I think,
go ahead.
I think, you know, making sure we're truly understanding what that patient's capacity is. So we're truly making the decision, do we focus on that patient or do we focus on that caregiver so that we can successfully get them to the next level of care?
Right, because the goals have to be realistic based on their cognitive abilities and all that. Yeah, that's going on. That's great. So, you know, under PPS, the way that it is now, the focus is obviously more on our therapy documentation than anything else when it comes to supporting the skilled services when we're talking about Medicare Part A, right? Now, with that shift, and we're going to talk a little bit next week with Sarah Wendell from the Clinical Strategies team about the physical therapist role, but there will be a more equitable sort of role for both nursing and therapists when it comes to documentation. So, you know, when you're thinking about how those pieces all fit together, what do occupational therapists maybe need to kind of think about in terms of supporting nursing documentation? Like, what types of things might they also be looking to support nursing as well?
Yeah, well, I think a big component, and we've talked about a lot of this that's reflective in the MDS, is the cognitive component along with the swallowing component. And for years and years and years, OTs really kind of said that, oh, that's speech therapy. Speech therapy does that. We have no skin in the game. But we know that it's going to take all of us. A lot of times OT is going to be in there before speech is. And we have a role to truly see, are we documenting if there's a swallowing issue? I mean, OTs do feeding. Are we looking at if the patient is having some difficulty? Are they pocketing food? I used to always say, as an OT, I do oral care with patients. If I'm seeing pocketing of food, that's an indication that there's a swallowing issue going on. Are we documenting that, number one? Are we notifying the speech therapist and nursing to, again, to have that collaborative effort and to do it timely? Because it's really all about capturing all of this in the early stages of the patient's journey that they're going to be with us in this post-acute setting. So doing that is one. Obviously, you know, OTs are now learning how to use the BIMs. Are we doing that? Are we understanding that piece of the cognitive component? But as we know, the BIMs in itself obviously is going to be reflective on the MDS. It impacts the nursing category along with the speech category, even if speech is not involved. So are we capturing that early enough? But then taking it to the next level as OTs, are we, as we have always talked about under safe transition, doing a more in-depth cognitive assessment, the slums, the MOCA. And some of our facilities are doing the pilot BCAT right now. So are we capturing that? Because we don't pick up on the subtleties of a cognitive impairment with the BIMS. But we also know that those are the patients that are at greater risk for rehospitalization, or having an unsafe occurrence happening, because they don't understand, they can't anticipate their actions, and that sort of thing. Or with new learning, things break down. So I always say OT does have a place in reflecting that and talking about that. Other avenues, we have Optima now, which I think is wonderful, capturing things such as a subtle thing of, does the person that has COPD, when lying flat, become short of breath? Do we put that into practice as therapists? Do we attempt to get them on a mat and document that? Because that's so important for nursing, because that impacts the nursing category. That ultimately puts them in, a special care high. Just that one behavioral difference. And then along with, when we talk about the BIMS, a score of, equal or less than 9 can impact the nursing category for, cognitive and behavioral issues. So we all have a role of understanding that, capturing that, focusing on assessing those key areas early on for that patient. Great.
So one of the things I want to talk a little bit about just real quick before we wrap up is, if you're a clinician with HealthPRO-Heritage, and many of you watching are, we have a lot of tools. You talked a little bit about Optima just briefly, and about how that might, what we're going to be documenting in those kinds of things in there. But what kind of resources, and if you're not with HealthPRO, ask about what you have available to you today. But Loretta, what kind of resources would you point our clinicians to that'll help you take care of all that, or think a little bit more holistically, like you talked a little bit about safe transitions and discharge and cognitive issues and all those kinds of things. What are some great just sort of go-to things for our OTs?
Okay, I think accessing the clinical resource file on the desktop is the first step. Once you open that up, there's a tremendous amount of resources. The test and measure clearinghouse goes into not only the BIMS is there, the MOCA, the slums, but we have additional assessments like the modified performance evaluation that really looks at the person's capacity functionally to be successful in the community. That may be a standardized test along with the Barthel. I always say to therapists, we really just can't do standardized tests, just do standardized tests. We want to be able to show where the patient is starting, and then with our intervention, our skilled service, where they get to. That's the outcomes. That's what's so important. We're not getting people to prior level of functioning anymore. It's really moving them to that next level of care. So within the test and clearinghouse, there's so much information. Safe Transitions is a folder and a framework all within there with tremendous information on health literacy, medication management. We've just increased and added an entire folder on group resources. That's going to be an expectation. And again, as occupational therapists, we need to be very mindful of the type of groups. They have to be functional based. They have to be able to capture the specific goals of that resident. It's no longer, they're in a group to have fun or to socialize. It's really, what are my goals? What is the expectation for this patient being in this group? And how is this group going to help improve my outcomes with this patient? It's got to be thoughtful. It also has to be reflective of that resident status. So I am a great component. I hear this all the time. Well, my patient has dementia or my patient has cognitive impairments, they're not appropriate for groups. Well, no, maybe not a high-level health literacy group that you're talking about the importance of weighing yourself if you have CHF. That may not be the best group for that person with dementia. But a do group reinforcing of a skill set is. And I think our clinicians have to be able to kind of decipher what type of group and when it's appropriate and use them accordingly.
So it's all about changing sort of your perspective of not just how we evaluate, but how we look at patients, again, in a more holistic way. And think, yeah, all of our tools can definitely help you do that. If you really want to feel like a clinician, use those tools, and I think you'll be able to do that. Well, thanks so much, Loretta. I really appreciate your time.
Just add one thing, because you know, I'm an OT for a very long time. You know, our whole premise started with function, right? The everyday tasks that people are able to do or need to do to be successful. Well, here's an opportunity where Medicare is telling us we recognize the impact function has on people's ability to gain and to improve. And as an occupational therapist, we need to get back to our roots, which is using function, no longer just doing busy tasks with our patients, really thoughtful in what we're doing. So I'm excited. I think, you know, change is scary, but ultimately, I think this is what we need to be doing as clinicians. It's really showing our worth and our value we bring to the table with our patients. So thank you. You talk.
I think you hit the nose on the head. Or the nail on the head. I don't know what this expression is. Anyway, thanks so much for joining us. If you have any questions for me and Loretta, let us know in the chat box below. We would be happy to answer them for you. We really appreciate your time. Thank you, Loretta. I really appreciate your time. Have a great day, guys, and happy documenting.
That's it.